Good afternoon or good morning, according to where you are in the world. We are really pleased to welcome you to the 9th annual joint webinar series in maternal and child health from Harvard and Boston University Centers of Excellence in MCH. I'll introduce myself first. I'm Lois McCloskey. I'm professor in community health sciences and director of the MCH Center of Excellence at BU. And my colleague Henning Thiemeyer, likewise, is the professor in the Department of Social Behavior Science and chair of MCH here at Harvard, also director of their Maternal and Child Health Center of Excellence. We are really happy to have our two staff members with us who made this happen. Kimberly Pinkowski, who works here at Harvard, and Anissa Saleh at the MCH Center of Excellence at BU. So together we welcome everyone. I want to note we have approximately almost 300 people signed up for this. I don't know right this moment how many are with us, but I do know that we have a global reach today, which is very exciting. Our webinar series is funded by the Maternal and Child Health Bureau, and its purpose is really to deliver each year some on a significant topic of the day with global importance for the maternal and child health workforce, broadly defined. We like to attract practitioners, clinicians, researchers, and today's topic could not be more important at this moment when a seamless system, wherever we live, that blends together primary care with mental health services, behavioral health services for children, for adolescents, and for adults likewise. Today, we're focusing more on children and families. And without further ado, I want to begin our webinar today, Integrating Family Behavioral Healthcare into Primary Care, with the Team Up team. I think there's no one better, at least in this country, who can talk to us about implementing that kind of seamless system of care. And so I specifically want to welcome you, Dr. Emily Feinberg, Implementation Director at Team Up and also professor at the Institute, I want to get this right, the Hassenfeld Child Health Institute at Brown University. And your other team members, Charlotte Vieira, who holds a master's in public health, Deputy Director for Model Implementation for Team Up, and Sonia Ehrlich, who is a mental health counselor, licensed, and plays the role of Deputy Director for Workforce Development and Training for Team Up. So without further ado, welcome to all of you. Emily, I believe you're starting.
Hi, everyone, both those of you here and those of you I can't see. It's kind of amazing that we're talking to so many people that we don't know where you are. But I hope that what we talk about today will be relevant for all of you. We will share our presentation. We have a couple of videos that we think explains about Team Up probably better than we can ourselves. And then we'll have some time for questions. I want to just acknowledge that we have nothing to disclose related to commercial interests, and to recognize our funders for Team Up, which is the Richard and Susan Smith Family Foundation and the Klarman Family Foundation. I'd also like to acknowledge both our other team members as well as the health centers with whom we've worked, who've really been critical in the co-development of this model. So I'm going to start why Team Up. Well, for one, we know if you open any newspaper or you listen to the news that there is a crisis in youth and family mental health. There's been a lot of focus that this has been exacerbated by COVID, which is true, but this certainly predates COVID. And it has not really improved since COVID. And if we look at some of the stats, it's really quite glaring that 1 in 5 children experience a mental health issue. Only 20% of those receive treatment, and the average delay from onset of a mental health symptoms to treatment can be up to 11 years. So we think of how we're leveraging the moment. I think there have been changes both at the federal and state level that have really made this time ripe for integrating models of behavioral health care into primary care. There's been a key Surgeon General's advisory that has talked about the need for improved mental health care for children, youth, and families. It's a statement here also by the American Academy of Pediatrics and also the American Academy of Child and Adolescent Psychiatry. And we've really seen a convergence of both government and professional organizations coming together and really advocating for youth mental health. If we think of it at the federal level, with this administration, there really has been a shift and an increased emphasis placed on mental health. And this article is referencing sort of a national roadmap to address behavioral health with a real focus on integrating those services into primary care. And when we think about why primary care from the pediatric perspective, I don't know how many people here or in the room or on the call are clinicians, but we see children and families very, very frequently, particularly in early childhood, and then hopefully yearly throughout school age and young adulthood. And that longitudinal connection with families and with children, I think gives primary care a real, very safe and non-stigmatizing place to address mental health issues, as well as about the opportunity for longitudinal relationships. There's some changes that have happened here in Massachusetts that I will talk about. I realize they're not relevant to everybody on the call, but I think they're interesting in terms of how one state has changed the context for implementation of integrated behavioral health. And I will talk about them a little bit more at the end of our presentation, but there have been two very instrumental changes in our state that make this a really sort of prime moment. One is the issuance of a behavioral health roadmap, which was introduced in 2021 under the previous administration and Mary Lou Sudders and implemented in 2023. And it's basically, the goal is that there's no wrong entry. One can enter into the behavioral system in a variety of places and hopefully have all their needs met. There is quite a long way for this to go to have this be reality, but there've been some very positive changes in improving access to services for kids and also really for adults. And the other is the state's Medicaid 1115 waiver, which has created new funding mechanism and new criteria for sort of structuring primary care and with a particular focus on mental health. And I'll talk about that more at the end of the talk. So going to Team Up, our goal has been to build the capacity of primary care to deliver an integrated behavioral health services. We have our vision, which is that all children and families will live within a community that fosters and promotes physical and behavioral health, wellness, and resilience. We've also, on this slide, you'll see our aim. I'm not going to read it off, but it's basically to promote positive child health and well-being. And who do we work with? Team Up has to date really worked primarily with children and families who receive their care through federally qualified community health centers. And we've been working together for the past 8 years and received really very generous funding. And we've worked with 7 community health centers. And we've listed here our key partners, which you can also see in this slide. And we've really had 2 phases. The first phase we call model development. When we first started thinking about how to integrate behavioral health services into primary care, we very quickly realized there was not a model that worked for community health centers. So we shifted, so it took a step backward and really thought about the co-creation of a model with our partnering health centers. And as you can see, the health centers that we've worked with primarily serve children of color. They are located around the state. And this second cohort, particularly Brockton and Greater New Bedford health centers, serve a large newcomer population. And what you can see at the bottom of the slide is how the integrated teams have been constructed. You can see that these are based on the size of the health center, so have between 3 and up to 6 behavioral health clinicians, and between 2 and 4 community health workers. Community health workers are a integral part of the team. They are seen as key personnel, and we'll talk a little bit more about that, I think, Sonia and Charlotte, when they present. I'm not gonna go over this model because there's a lot of text, but just to say that we do have a transformation model, and we think about it as transforming care, strengthening the foundations within the health center to support that care transformation. That's supported by creating a learning community, which involves training the staff at the health centers. And we also are at a point in our development where we're really thinking about how to lead systems level change and how to scale and sustain the transformation. We also have an independent evaluation team, which I'll cite some of the work that they've done toward the end of the presentation. But we think it's also really important, in addition to the work that we're doing on the ground, to be able to make the case for its effectiveness within the academic community. So this just kind of shows you the different components of Team Up. There's practice transformation and clinical training. And what I'd like to do now is show you a video that introduces Team Up, and then after that, we'll turn the presentation over to Charlotte. Let's see if I can make this happen. Here's my.
Click on that. Yeah.
Sorry, we have a little technical difficulty. Okay, sorry, thanks. Oh, no, sorry.
The world needs to move towards integration. We can all see and feel, even in our own lives, the pitfalls of fractured, fragmented care.
With so much that's unpredictable, one of the best things that we can do is really team up to try to address those things together in the long term.
I think the original vision for Team Up was to expand access to child mental health services at federally qualified health centers. There was a sense of promoting health equity and a recognition that the population served at the health centers often had difficulty accessing mental health services.
There was a deficit, kind of peer-reviewed literature that spoke to how to provide really high-quality, evidence-informed behavioral health care within the environment of pediatrics of primary care. There were not models to take off the shelf. It doesn't work to hand over a model to a health center and ask that health center to implement that model. The guiding principles of what it is that we're trying to achieve need to be the core essence of what everybody is signing on to do together.
The Team Up model really does a nice job in bringing the behavioral health side of things with the medical side of things, with the inclusion of BHCs and also with the inclusion of community health workers. The three roles together really have the opportunity to provide quality care, particularly for the marginalized, high-risk population.
This kind of research is not rocket science. Rocket science is way easier. And the reason rocket science is way easier is that it's more predictable. My hope is that Team Up can be part of the solution to really shifting toward thinking about the voices of all kinds of people from all kinds of different populations in a different way, and really thinking about equity more deeply. There's not as much evidence on populations that have been historically oppressed in different ways. As a researcher, I think the clear imperative is to really deepen the evidence base so that we can say with more confidence what works for a very diverse range of people.
There's a lot of hierarchy in the medical profession, and I think that Team Up has consciously acknowledged that and recognizes it as something that needs to be addressed.
We have to look beyond traditionally trained psychotherapists, psychologists, psychiatrists, to look towards who are already existing role models in communities. The community health worker role that is part of the Team Up model is a really good example of this.
It's truly that human interaction, that therapeutic approach, and that ability to connect with families that's really truly going to make an impact on how we're delivering care and impact on the health outcomes for the families and their children.
I think it would be hard to do the work that we do without these spaces where we can do a mix of supporting sites individually and also creating spaces where people can just develop relationships across health centers.
Team Up has really been a wonderful platform, not only to directly change the experience of patients and families in Team Up health centers, directly change the experience of the healthcare team in delivering that care, but also through the learning that has happened through this initiative to work on changing at the policy level our expectations for what we would like our healthcare system to be like and how we would like it to function for all of us.
Some of the best examples of people, like the relationships that have been formed and people taking the supports that we've put in place and taking advantage of those relationships, is when I hear from practices that they're meeting together without us. And that's actually the best feeling.
I think the future is integrating mental health, well-being, therapeutic, social, emotional understanding into all of our infrastructures, into schools, and into our medical care, into our workplaces, into all the spaces that we share together. The bigger picture is how to set up structures that mediate stress and burnout and sustain us in a way where we're taking care of each other.
I think a lot about the next generation.
I think that it's clear, based on my experience here, that I definitely want to be in a place where the values regarding one's wellness and social connection and belonging is embodied by the people that you're working with, and also your coworkers and your supervisors.
I hope that any number of practices, federally qualified health centers, but also private practices, large health systems, are able to capitalize on the learning and the Team Up has made. If I was to go, 10 years forward, I would hope that the Team Up almost is such an established part of how we think about providing behavioral health care to children and families that maybe it's even an afterthought. It's just taken as a standard part of healthcare.
So we can't really think about any of this work without the people who are in the healthcare systems delivering the care. So we thought a lot about what kind of training and supports were needed for the integrated care team, some of whom you just saw in the video. The care team that we think about for the integrated care in the medical home are the primary care physicians, primary care providers, behavioral health clinicians, and the community health workers, sometimes called family partners. Of course, everyone on the care team plays a role, and we really ideally would like to be just greasing the wheels of the whole system to work together. But in the Team Up model, that's really kind of our captive audience. And thinking about the training that people often come in with in those roles, primary care providers are often trained, very strictly in medical care, which in medical school historically, or nurse practitioner school, the medical can be very, the physical health can be very separate from the mental health. And so, even if someone has had rotations in psychiatry, we've noticed that there's often a road to travel to get people to the point of being comfortable assessing and diagnosing and sort of knowing when there's a mental health need specifically. And then behavioral health clinicians are often still trained in the kind of old school 50-minute hour, outpatient style of therapy. So it can be a very different experience for people to come out of grad school and go into this kind of work in integrated behavioral health care. It's a very different approach. It's just a different way of providing your therapeutic services. And then community health workers, there really hasn't been a very consistent standard of training. People are coming in with all different educational backgrounds and lived experiences and professional experiences. So we've really tried to develop a system, a training curriculum that thinks about the kind of core skills, the core competencies that best prepare all of these roles to deliver integrated care and to work alongside each other at the top of everyone's scope. So some of our kind of guiding principles as we've developed our curriculum are that the care and the approach needs to be trauma informed, and that requires not just training direct care providers in a trauma informed approach, but it actually requires training the whole system and training leadership and the kind of looking at the whole organizational structure to be that trauma informed container for people who are delivering trauma informed care. We recognize that everything always needs to be mindful of cultural adaptations. Each of the health centers has a really unique patient profile. depending on where they are, where they're located in Massachusetts, and also just kind of historically, like who has gone there, then family members go and friends, and the patient population kind of gets defined in that way. And then always adaptations for primary care. There can be the most excellent model that's been designed for, weekly outpatient therapy or an inpatient setting with a captive audience who's there every day. But if the model is not adapted for the primary care environment, kind of knowing what people's way of interacting with that setting is, then it's not going to land. So those have been some of our guiding principles. And as Emily mentioned, this whole initiative really has been a co-development. So we started with an initial cohort, had a lot of experts training in wonderful content. And then we just got a ton of feedback about, well, this works for our patient population. This is actually just getting people frustrated because it's not really designed for this context. So, getting a lot of feedback, identifying the need for adaptation, and then kind of really documenting what are the core principles and components that make people feel successful at their work. And we're constantly monitoring the need for additional adaptations. Charlotte is in direct contact with all of the health centers on a regular cadence. So is always getting feedback. And then we adapt, and we implement those changes. So this is just a visual of what you receive if you are a partner, a Team Up Health Center partner. The integrated care team receives role-focused training because we recognize that everyone brings a very unique lens. The community health worker adds to the care team in a way that the PCPs, the BHCs just won't do. So there's a real need for role-focused training and for kind of getting into people's very specific scope and expanding the knowledge base from there. But then there's also a need for interdisciplinary training. So we have often in the organizational trainings, the trauma-informed environment trainings are interdisciplinary. Racial equity in healthcare is interdisciplinary. And our supervisor consultations are thought of, thinking about the whole care team. We have an e-course so that there's an opportunity for asynchronous learning and sort of ongoing, just kind of keeping up your skills. And then we have supplemental trainings that have really been responsive to different times and different needs. The Special Topics Forum was developed in response to COVID when we just kind of overnight went into providing remote care. And so our very first Special Forums topic was on quite literally, how do you do a telehealth session? And then, as it grew, it was like, okay, how do you do a meaningful telehealth session when the child doesn't want to sit in front of a TV screen, a video screen, and there's all this stuff going on in the background. And now, as it's grown, it's almost like a kind of grand rounds for integrated care. So we have specialists from Boston Medical Center and then actually all over Boston and the Commonwealth, providing trainings on, for instance, like how to run a trauma-informed group, how to adapt treatments for OCD to primary care, things like that. Oops. So, and we really, as we think about the needs for clinical training, we're always thinking about how to take care of our workforce. We know we saw this mass exodus from the healthcare field during COVID, but really we haven't quite rebounded from that yet. It's still very hard to find a provider. People are still waiting on wait lists for a really long time. I think, as Emily was saying, integrated care really is one of the best ways that we can get people in the door to see a behavioral health provider. We know that, private practice doesn't really move the needle in terms of access. People can really cherry pick. Integrated care means that anyone who is part of that medical home is a patient. And we are very mindful of not burning out the people in our health center, in the health center partners. So these are some of our just results from our cohort 1 and cohort 2 studies of provider burnout. And I think just one thing to note was that during the pandemic, compared to the national average, PCPs and behavioral health clinicians reported lower levels of burnout at our partner health centers. And a lot of that we attribute to the interdisciplinary care team. So some of our routine efforts to promote sustainability are to keep building this learning community for peer connection, resource sharing, and professional growth. It doesn't necessarily seem like a radical act, but in a system that can be really driven by productivity demands and how many people you're seeing, taking an hour out for your own learning of your day, that can feel like a really big deal. And so we try to protect that time for our partners. We offer weekly self-care for healthcare workers. All of this is over Zoom. We provide organizational training to develop a trauma-informed work environment. Again, so it's not just the direct care providers who are thinking about these kinds of needs. And then to protect team time for interdisciplinary learning and communication. I'm gonna turn it over to Charlotte. One more graphic, just to say, these are some of the things that we've done through the learning community.
And I'm going to talk a little bit about kind of the other side of our learning community. So really thinking about the work that we do to support practice transformation across all of these health centers that are participating. So when we talk about practice transformation, there's quite a few things that we think about, but ultimately this is really supporting the sites that we work with to build the infrastructure and the systems that are going to support all of this work happening. As my colleagues have said, this is a pretty big shift in primary care, and so there's a lot that we really need to think about at the outset and throughout to make sure that this is successful and sustainable. So some of these things include just general kind of readiness up front. So thinking about, not only just building the team, but also bringing leadership at these sites into the process to make sure that there's really good buy-in, that there's champions on site that are going to be able to support this work. We do work around just the revenue to support the actual model itself through these new services that are added, functionality within the electronic medical record to make sure that documentation captures behavioral health needs and is also available across this new interdisciplinary team. And then, of course, sort of thinking about what Sonia mentioned, the training and just kind of the staffing of that team with these augmented roles of the behavioral health clinician and the CHW. So then we also think about kind of what we consider our core workflows. So these we would like to see every team at practice really implement within their approach. And these span kind of preventive touches that can happen with families that are coming in, augmentation of screening that they do as part of the well visit for children to really look at social, developmental, and behavioral needs universally across the pediatric population. Warm handoffs so that when there is a need identified, those complementary staff on the team can come in the moment and address that. Emily will talk about this, but some of our research has found that those warm handoffs are really key for engagement. Again, I mentioned the EMR piece, really thinking about what does the documentation across this team look like? And then for anything that can't be addressed in the medical home, really good coordination, navigation to external services and supports. We also think one of the things that's unique about Team Up is we focus across the pediatric lifespan. So we're not targeting any particular needs, any particular age groups. One of the things, so our core workflows are really meant to work for all ages, all children and adolescents that receive care in these medical centers. And then we also think about some condition-specific workflows, and sites will kind of take and sort of focus in on the things that are most relevant for their pediatric patient population. These are some of the things that are most common across all pediatric practices, and so where we've spent a lot of time focusing in really making sure that there are clinical pathways in place to address these common needs. And then one of the ways that we support all of this through the learning community is just through direct technical assistance support for our partners. So we have a lot of different sessions that are really aimed at quality improvement work. We talked about this in the video, but one of the strengths of this is really the community that gets built. So sites being able to share with one another. That's really vital for this. And then a really robust data platform that is built through the evaluation work that Emily mentioned that we're able to utilize in real time for implementation support. And Sonia, I think, showed a graphic similar to this, but we're really trying to kind of think about working across the health center as a whole instead of just focusing on those clinical roles that are providing care. This is a deeper look into those 3 distinct roles on the care team and kind of the unique scopes of work for each of those roles as we think about how they function in an integrated team. I think it's both important they're getting the training to support their ability to deliver the responsibilities within their scope. We're doing a lot of support to also make sure that the workflows are in place and that there's kind of good team coordination so that everyone can do their unique role. This is just an example. So when we think about those workflows, what does that mean? So kind of how patients move through the clinic, how we would think about sort of these different roles interacting together, not too far. But just working with sites to really operationalize this because we want this to be something that is streamlined. We also want it to be something sustainable. So do a lot of technical assistance support in how do we make sure that these workflows are well established, are working well, and that we're able to improve over time as the situation changes. I mentioned the data that we use from the evaluation. This is just an example of this. This is a dashboard that we have access to on a regular basis that our evaluation team generates for us. Essentially, though, that we have these indicators and many others that we're really monitoring month to month and using to inform the technical assistance support that we do, and really encouraging sites to integrate data as part of the way they think about their care delivery and improvement process. And then I mentioned at the start, the piece of our work that's focused around revenue. This is really key to sustainability. If people can't pay for this model, they're not going to be able to sustain it. This is one of the elements of our technical assistance support that really grew out of that kind of co-development piece, recognizing early on in our first cohort that this was going to be pretty key. And working together with our sites to kind of pull resources that will really help each of the teams optimize how they are generating revenue from these new services. So there's all sorts of work that's happening, but are they billing for it in the most appropriate way, in a way that's going to sustain this long term? So that's what I'd like to say just about kind of the practice transformation approach. We do have another video that I'll maybe start, or
I think we need to skip.
okay, yeah, thank you. This will be available. I think it's a really nice picture of kind of what this looks like at the health center, so folks can kind of take a look.
We want to, I'll be quick, and we want to leave time for questions. So we're going to just end by giving some overview of the way that we've approached building evidence around the model and supporting sustainability. So in terms of outcomes, we have looked at improved identification of child behavioral health issues in terms of screening. And what you can see is that the screening among the Team Up Health Centers exceeds that for the state average, and that cohort 2 has improved over cohort 1. And I think most encouraging is that we have not seen any clinically significant difference in screening based on child's race, ethnicity, or language. We mentioned about warm handoffs. We've done some studies that looked at the likelihood or the association between having a warm handoff and engagement in behavioral health care. And we've also found that that warm handoff really has a positive effect on engagement. We did a cohort study that looked at, a small cohort study that looked at improved child behavioral health symptoms and health-related quality of life and school attendance over a year period. And we also looked at prescribing, because one of the fears of our funders and also of others is whether this is a model that just increases inappropriate prescribing. We saw no increase in psychotropic prescribing and a decline in polypharmacy, which we think is a good thing. Sonia mentioned the issue of workforce wellness. And then in terms of cost, we've seen no change in costs, overall costs, but an increase in primary care visits. These are just slides that you can have. They reference some of the articles that have come out. I'm just going to go through them. And then just briefly about spread and dissemination. So Team Up has moved in our work beyond the health centers, where we are now partnering with the Mass Department of Public Health on a grant transforming pediatrics for early childhood, and working with colleagues in Rhode Island to help train community health workers who are being added to pediatric practices to expand the reach of behavioral health in those practices. There are two new things I think are worth mentioning in terms of supporting sustainability. One is the shift toward the ability to bill, this is all through Mass Health, our Medicaid program, for preventive services. And this is huge, particularly for early childhood, where young children don't often have a diagnosis that's billable. And probably the more, what we think is the most significant change will be the funding for team-based care under the state's Medicaid Mass Health 1115 waiver. I'm just going to say what a waiver is. Do people know what the waiver is? Yes, some do. Okay. So this is an agreement between a state Medicaid agency and CMS, and it allows flexibility in the program beyond what's allowable. And what's happening in Massachusetts is we have what's called the primary care subcapitation program. And it's instead of fee for service, we're going to a per member per month way of reimbursing or paying for services. And what we have now are 3 tiers. And I think what's significant is that if you look at that, you can see that there are there's quite a significant emphasis on integrated behavioral health, and that in order to reach the 3rd tier, for example, you need to have team-based roles at each site, including a behavioral health clinician or a peer family navigator, CHW, or a full-time on-site staff with children, youth, and family-specific experience. We're not sure what this is going to mean in the current environment, whether these funds are sufficient to really support the kind of work that one needs to do for integrated behavioral health. But we're hopeful that it may make a difference because it's really moving beyond just reimbursing a primary care provider for illness-based visits to thinking more creatively about how to use different roles to support wider behavioral health needs. I'm going to stop here and open for questions.
So, hello, my name is Henning Thiemeyer. I'm one of the hosts together with Lois. Let's open for questions, but let me first thank you all. Thank you, the three speakers. Emily, Charlotte, Sonia, thank you very much. It's a pity we missed the video, I must say, and we do apologize for the late start because that was the price we paid, but that was a bit about the content, so thank you very much for the talk. But as we can share that online, we'll find out how we can insert that anyway, even if it's not shown in this slide presentation. I'll open for questions. I think Lois is collecting them from, but I have, yes, the audience first here in the room to sort of give us a bonus for those people that came. Could you please give us your questions? Go ahead.
I wanted to hear a little bit about the selection of the community health centers and if there was any kind of differential reception of these programs, like did certain communities respond well or not as well?
Yes, yeah, to me. So the foundations actually led the selection of sites. And all sites, there was a general request for applications. There was an application process that looked at site readiness and sort of both the commitment of leadership and the resources that were there. And then there were site interviews and then a selection process. And I think in thinking about the applications that we received, there were some sites that honestly just didn't have the infrastructure that would be able to support the work that we were asking sites at this time. We felt it was really important to get experience in implementing the model as we envisioned it, so that we wanted to work with sites that had that capacity to do so. I think we now think a little more flexibly as we think about spread and realizing that there are ways we can support sites who are at really various stages in both the behavioral health services they provide and in the level of integration.
I had one thing to know. Just also to say that we did have one site that started out with no behavioral health history, but they had very strong internal championing of the initiative. So that's, it's not like everyone had the same starting point.
Thank you. We have one question. Here are several coming from online. Someone noted that one slide mentioned that a perinatal mental health was one of the focused work streams for some locations. Tell us more about that. What does that mean in the context of pediatric focused programming?
I can start and then you can. So many of the sites do routine screening for maternal depression as part of the pediatric well child visit. So we do consider the child's caregiver as part of that family and part of someone who can be served by Team Up, and that might be connecting that person to on-site services, or it might be connecting them to outside services or support groups. There's also work that's been done at each site different sites about linking prenatal and postnatal, and also about what we call a preventive touch. And I'm going to turn to Charlotte to explain.
Yeah, so we do work with sites to kind of think about like what types of services are happening within their health center, within their community that are aimed more in the prenatal period. and support sites to think about kind of a linkage there. Often these services are also happening within the health center. And so they're also getting some type of depression screening, mental health screening as part of their prenatal care. And what we've really tried to establish as a way to kind of build this bridge is that robust connection between the departments. So if we know that there's a family that is receiving prenatal care and there's a concern around mental health, or there's a need or a risk factor, connecting that with the pediatric team so that when the family progresses into pediatrics, they're well established, they know what's going on, and they can support that family. As Emily said, another piece that kind of intersects with this is the universal touch. And this is something we've worked with sites to establish in the newborn period within the first 2 months of a child's life. Even if the family hasn't been identified with some sort of risk factor, a touch point for every single family coming in to introduce the existence of this team, this integrated team, and to do some kind of brief psychoeducation support around new parent stress and kind of early child development. And so that kind of supports what we like to think of as kind of a continuum of services to really make sure there's good support in this age range.
Another question.
One quick clarification one, and then one that's more about policy. Just to clarify, which specialty disciplines are included under behavioral health clinician?
Social workers, they're psychology fellows that are involved in our learning community, licensed mental health clinicians. I don't know if we have any right now, but licensed marriage and family therapists. Yeah.
Thank you. And I'm wondering if we could wrap up with you reflecting on, especially for those in the audience who are from other states, they have different waivers, perhaps different, less progressive, perhaps mass Medicaid systems and policies. For those working in local or state health departments or in the advocacy or clinical communities, what would you recommend be their ways that they might initiate such a program or advocate for policy change that's most critical in their own state or locale?
I'm going to answer that a little bit sideways, but the biggest challenge in sustaining the role is lack of funding or lack of adequate funding for community health workers. And we believe that this model can't be implemented without them. And so I think in terms of advocacy, really advocacy for whether that's for ways of payment, whether that's sort of through expanded models like they're doing in Massachusetts that sort of go to a more broad capitated payment, or whether there's adequate fee for service reimbursement for the work that they do. It's actually, community health workers are reimbursed in a number of states, but it's questionable whether it's sustainable. So I think there definitely is advocacy needed for the community health worker role. And I think there's also advocacy needed around workforce development, because every state, every place is facing a shortage of clinicians, and particularly clinicians of color. So I think state policies and programs that provide loan forgiveness, that provide scholarships and stipends for trainees, that are trainees who trained within the type of community organizations and institutions where they're most needed, is another policy that is worth advocating for.
Great.
Thank you. Yes, Emily, thank you. Thank you all three again. Sonia, Charlotte, Emily, thank you for coming to Boston to the Harvard School of Public Health. Thank you, Kimberly, Vanessa, for organizing. Thank you.
Let's wrap up with reminding you that we will send slides to all who registered, and they include a web address where you can find all of our joint webinars archived, covering topics that include substance abuse disorder for women, children, and families treatment, prevention, as midwifery. We have several on that topic and others. Please check them out. And thank you all from around the world for attending.
Thank you very much for coming.